Good evening to everyone, and thank you for making the time. Thank you to Dr. Bailey Stanton for giving me this opportunity. And as she introduced myself, I'm Dr. Phumudzo Tshigabe. I'm one of the Bara ICU MOs. Should we give it a few more minutes or should we start?
I'm pretty sure that you can start. People might
Okay.
join a little bit late, but it's totally cool. There's lots of people online already.
Okay. So the talk is fungal sepsis in ICU. I know we're all from different backgrounds, but I hope you'll find this talk refreshing and interesting and a bit of a refresher of previous knowledge that we have. So an outline to the talk that I'm going to give will go through some introduction, definitions, classifications, risk factors, different classes of antifungals, a diagnosis and approach, management in the ICU, and then we'll end off with the conclusion. So what is a fungus? Depending on your weekend activities or your daily activities, you might interact with different types of fungi or funguses. If you enjoy cooking, maybe use mushrooms, or you get mold on your favorite fruits and vegetables, or you might be a bit sick and you're using some antibiotics, namely penicillin, or you enjoy baking, where you use yeast, or maybe the occasional ethanol on the weekend, where you enjoy beer. So what is a fungus? So opposite to contrary belief and what most practitioners do, it's not a raised BDG with low platelets. Rather, there are multiple definitions for fungus. The one that I like is that a fungi is a eukaryotic organism that includes microorganisms such as yeast, molds, and mushrooms. These organisms are classified under the kingdom fungi. The organisms found in the kingdom fungi contain a cell wall and are omnipresent. They are classified as heterotrophs among the living organisms. Just to break that definition down a little bit further, a eukaryotic organism is any organism that has a defined nucleus, which is encapsulated by a cell membrane or cell wall. Omnipresent, it's often referred in religious context where the Lord is omnipresent, which basically means it's everywhere. And heterotroph is a organism that cannot create its own food, and in the case of fungi, they usually decay. So looking at fungal cells under the microscope, we can see that they're actually very similar to animal cells and bacteria cells, and they share a host of organelles. But the important difference is in the cell wall and the cell membrane. I think this is one of the more important slides as it will show you how we treat fungal infections and how we diagnose them. So if you take in a closer look to the cell wall and cell membrane, the cell wall is made of proteins, and namely beta-glucan, which is a famous one, which most of us know, chitin, and in the cell membrane, there's ergosterol, which is different to cholesterol, which is found in animal and bacterial cells. On the right-hand side is just a further breakdown of the proteins. The top layer is mannan proteins, and then you have your beta-glucans and your chitins. So there are different ways of classifying fungi. We can go on a cellular level. So you have unicellular, multicellular, and you have some that exist as both. Our unicellular ones are often our yeast and our cryptococcus. Under yeast, we have all our Candida species, with albicans being the most prevalent one, and then glabrata, parapsilosis, cruzi, tropicalis, and auris. Our cryptococcus, our neoforms, we know usually from meningitis, and our gattae usually causes pneumonias. Multicellular ones are molds such as our aspergillus and our mucorales species. And then you get funguses which exist as both unicellular and multicellular depending on the environment. And these are called dimorphics. So these are histoplasmosis, penicillosis, mycosis species, and our sporotrichosis, also known as rose gardeners. So how they decide on which whether the unicellular or multicellular is dependent on the environment. So mostly in a cold environment, they exist as multicellular, and in a warm environment, such as in humans, they become unicellular. Our dermatophytes, these are based off where they exist anatomically in the body. They need keratin to survive, and there's common layman terms like athlete's foot, jock itch, nails, tinea which is found in the nails. And these are actually don't give so much morbidity or mortality, although they do keep our dermatological friends busy, as they are often very hard to eradicate and treat. Another way we can classify our fungus is where they appear. So you have your superficial, which are dermatophytes, which you mentioned, mucocutaneous, which is our oral, esophageal, and vaginitis. This usually causes thrush. Subcutaneous, which is our sporotrichosis, our deep primary and meningitis and pulmonary. And then the ones that we usually focus on is our deep opportunistic, which we mainly find in a hospital setting and ICU. These cause these are usually our Candida species, our Cryptococcus aspergillosis. These cause meningitis, bloodstream infections, pulmonary infections, and ophthalmitis. An important one to remember is mucormycosis. This is usually very severe in diabetics. It starts in the nose, and it spreads through the cribriform plate, eventually causing a meningitis, and it's often very lethal. So there are different risk factors to fungal infections, and what we have to remember with fungal infections, they're usually opportunistic infections. So anything that will make you vulnerable to such usually becomes a risk factor. At Bara ICU study, they did a study. They did a study to see what is the most common risk factors, and broad spectrum antibiotics were amongst the highest at 100%. The reason for this is that we often then wipe out our commensal bacteria, and that allows for opportunistic overgrowth of fungus in our body, which are often commensals. Intubated patients, central lines, urinary catheters, and TPM. Another important thing to remember is funguses like creating a biofilm, especially on plastics. So that's why our lines are always risk factors. A more comprehensive list of risk factors. And if you just take a brief look through this, you'll see that actually most of our ICU patients at least have one of these risk factors. And it all has to do with either creating a biofilm or decreasing your immunity, making you vulnerable. So immunocompromised patients, critically ill patients, intra-abdominal surgery, which is half of our ICU patients. Most of our patients get lines in ICU and invasive devices. TPN, based off the fact that we give it through central lines, our broad spectrum antibiotics, which you mentioned, dialysis, organ transplant, diabetes, our burns patients, trauma patients, long steroid use again with your immune system, mechanical ventilation, as we often have ET tubes inside you, which are also biofilm creators. So how do we diagnose these fungal infections? There's different methods: microscope, cultures, biochemistry, radiology, scoring, and predictive systems. So if we take a look under the microscope, if we go back to med school, you remember that potassium hydroxide is one way. How it works, it dissolves all the keratin cells and then it just leaves the fungal cells intact. Calcofluor white, it binds to the chitin. If you remember in our first slide, that was one of the layers in the cell wall, and you get these fluorescent white looking cells under the microscope. India ink, a famous one we use usually for our meningitis or CSF stains, and how this works, it dyes everything in the CSF black, and all that you see remaining is these white spots of fungal cells. Cultures, the pros of cultures, these are readily available. The good thing is it provides susceptibility, although there's no evidence on using fungal specific culture bottles versus generic culture bottles. The cons of cultures is that they often take long. There's a sterile factor, and in most times we only get 50% sensitivity or don't grow fungus at all. It was also the clinical practitioner dependent on getting the right or adequate sample into the blood culture. PCR, this is newer technology. It provides quick results, although it identifies the exact species. Unfortunately, it doesn't give susceptibility to what antifungals we can use. They're often very expensive and there's very poor standardization. There are new tests on the market. although not often available in our setting, such as antigen and antibody states. And also, again, if you remember in our first slide, there was mannan in the cell wall. So there's galactomannan assays, which are also created. And then our famous beta-D-glucan, again, that comes from our cell wall. The issue with it is there's a lot of things that can provide false positives, such as our antibiotics, immunoglobulin, albumin, patients on dialysis, again, patients who have had surgery and there's cause in situ, or any bacterial infections. We often use a diagnostic value of more than 80, although there's have been cited ways where we can make this more sensitive. For example, using a cutoff value of more than 200, or maybe doing zero beta-G glucans where you see it's at a same state or becomes elevated. And it's also important to know that not all fungal species at the same levels of beta-D glucans. For example, in Candida parapsilosis and Candida auris, they usually have low levels. And then another thing, it's non-specific. Besides all of these negative points, it does have a high negative predictive value. So we can use it as a rule out test if our BDG comes back as less than 80. So our different classes of antifungals, pharmacology, there are polyenes, they bind to ergosterol and cause pores to develop in the cell membrane. Our azole, these inhibit selenasterol 14 alpha demethylase. And again, that's just acting on our ergosterol synthesis. And lastly, our echinocandidates that inhibit beta-1,3 glucan synthase. So you can see most of these drugs have some part in the cell wall or cell membrane synthesis. Just going further into the different types of classes of antifungals, we have our polyenes, which is our amphotericin B, our nystatin. These are broad spectrum, although they can cross-react with cholesterol, which is in our animal cells and bacterial cells, and hence why they have a lot of side effects, such as nephrotoxicity. You get infusion reactions. They have a long half-life of about 15 days. And other side effects is electrolyte disorders, phlebitis, and we often use them as a last resort due to the toxicity. There are newer drugs on the market which are liposomal based, and basically what they do, the amphotericin is hidden inside a liposomal ring, and this allows it to be transported until it reaches the fungal cell. That liposomal ring lyses, and then the drug is exposed to the fungal cell. Our azoles, our famous fluconazole that we all use most of the time, itraconazole, voriconazole, and as stated, this is usually our first line treatment, especially for Candida, although they also do have side effects such as hepatotoxicity, raised LFTs, drug-on-drug reactions, and relatively fluconazole causes alopecia, itraconazole causes hypertension, and voriconazole can cause photosensitivity. For our mucocutaneous infections, we usually use clotrimazole, such as in our vaginitis and thrush. We usually prescribe things like clotrimazole pessaries, and they're often weak against certain species like our glabrata. Our echinocandidates, these are cuspifungans and mycofungans. These are fungostatic drugs, so you can remember that they're fantastic drugs, although they're very expensive. But having made that statement, all antifungals are expensive. It's just echinocandins are the most expensive. And it's often weak against aspergillus. So phases of therapy, this is often a retrospective view, or you might be asking yourself, who should we start treatment on? So there's different groups. There's prophylaxis. Basically, you're treating based on patients who you believe are at risk. Empiric treatment, patients who might have risk factors and are becoming ill in your ICU, such as having a prolonged fever. And preemptive is where we have features that are suggestive of fungus, but we have actually not confirmed the diagnosis, such as our raised beta-D glucan, CT scan findings. Just to go through some of the CT scan findings, often common words we use is like our ring enhancing lesions on our CT brain, our halo signs, and which is linked to aspergillus, air crescent sign, and our tree in a bud sign. Then lastly, we have targeted treatment, which is the gold standard. This is where we have a biopsy or we've cultured fungus. Um, Often there's different guidelines on when to start, but if you look to the right, this is just a graph to show that most patients who are put on prophylactic treatment, we often don't end up culturing a fungus. And as you go further down the line, empiric becomes more sensitive, preemptive. And this, according to this slide, is that's when they suggest we should start. So if you have like a raised beta D glucan with patients with risk factors and either positive features on CT scan. And lastly, culture proven candidiasis. So how do we manage an ICU? Always remember it's our patient first. So we treat the ABCs and we'll see the fungus later. Once your patient is stable, then you can ask yourself 4 simple questions on which antifungal to start. So the first question is your patient neutropenic? Is your patient unstable? Has your patient received any azole? Is there any azole resistance in the unit that you are working in? If you answer no to all of these, then you can start treatment with fluconazole. But sadly, if you answer yes to any one of them, we have to upgrade our treatment to either an echinocandins or a polyene. And this is, I think, also why it's important, not why we don't just treat with prophylactically, because usually we use fluconazole, and you'll see by the time your patient becomes sick, our options become limited. So our management in ICU continued. As discussed, we said preemptive is probably the best point to start. What dose? Our fluconazole, we mostly use a standard dose of 400 milligrams BD, but it's actually been shown that we should use weight-adjusted doses with a loading dose of 8 milligrams per kilo and a maintenance dose of 6 milligrams per kilogram. Likewise with our ampho, although mycofungin, we can use 100 milligrams daily. It is also remember to de-escalate when appropriate, which links in with our antimicrobial stewardship. So once you get culture results or sensitivity, that's when we provide targeted treatment. Maybe you're on mycofungin due to the other 4 questions you answered, but now we get a culture saying sensitive to fluconazole. So once you have your sensitivity and you're on the correct treatment, when do we stop treatment? And the answer is 14 days post-negative culture. Important points just to re-emphasize again is that our funguses love creating biofilms, so remove and change all your catheters and lines. Always get an abdom consult for invasive infections. And again, number one thing is source control. So if there's abdominal issues or collections, get the surgeons involved. Then review after 48 hours. And if you're ever in doubt, always just consult micro. They're just a phone call away. So who do we not treat? As mentioned earlier, we do have colonizers in our body, but they are not invasive. So for example, you might culture from urine or the respiratory tract, but there's no evidence of leukocytes or pneumonia. So those patients, we do not have to treat the fungal infection. These are risk and predictive scores. They were invented just to try and make our empiric treatment robust. There's 3 that are relevant, which is our colonization index. This is quite, how do I say, time consuming. And basically what happens is when a patient enters your ICU, you have to culture your patients twice weekly from different sites. This is anything from skin, urine, tracheal aspirates, and blood cultures, and then you get a ratio. And if it's more than 0.5, they say you can start empiric treatment. So this is something you could do while waiting for like a BDG or your cultures, and you're worried that your patient is not doing so well. Another one is Candida score. You can see these are based off risk factors. So any surgery in ICU, TPN, severe sepsis, or your Candida colonization index, each one gets a point. And if you have more than 2.5 points, they say start treatment. Our predictive rule, again, you can see it's based on risk factors. So if you have sepsis, any central lines, mechanical ventilation, and the last 2 you can see it's again from the biofilm, and any one of those risk factors, they say start empirical treatment. The most robust one out of these is the colonization index, because then as you can see at the bottom, about 85 to 90% grow positive cultures, where on our predictive rule, only 60 to 75% come back with positive cultures. And lastly, just to end off with some points of interest, PCP, PJP, what is the exact term? Is it a parasite? Is it a bacteria? Is it a fungus? So previously they used to refer it to as PCP because of pneumocystis carinii pneumonia. And then they actually said the new term should be PJP, just to honor where it came from and the pathophysiology. But due to the medical fraternity being resistant, like these funguses that we treat, they were smart and they just kept the citus, so it still became PCP, pneumocystis pneumonia. And what is it? So originally it was thought to be a parasite. It's not a bacteria, although we do treat it with antibacterials. And the reason is it's going back to our first slide. The antibacterials cross-react more with they don't really produce so much agosarol and beta-D-glucan. Our Nocardia and Actomyces, these mimic funguses, but they're actually bacteria, and we treat them with antibiotics. An interesting one, but simple answer is nystatin. It's actually a polyene like amphil, but it's said to be 10 times more toxic. So then you might ask yourself why we use it. And the only reason is because we use it orally and not IV. So as you can see in this whole presentation, there was no reference to any platelets. And in most guidelines, they don't quote platelets. However, where do platelets come in? They actually contribute to the immune response, and certain fungal infections made a great elicit a greater immune response. So you get platelet aggregation and adhesion, and that's why you have low platelets. And just in conclusion, fungal infections can be life-threatening, always have a high index of suspicion. Culture and histopathology is the gold standard, as seeing is always believing. Antimicrobial stewardship programs, specifically targeted therapy, and always remember to de-escalate. Fungal infections on the rise, that is a pun which is intended, if you remember from the first slide with our yeast and bread. There's increasing resistance, and always consider other differentials. And as always, our patients come first with your ABCs. I hope you enjoyed this presentation. It was a quick and short one. I did try to be a fun guy. That is another pun. And thank you to Dr. Bailey Stanton for giving me this opportunity.